Hi, and welcome. I would like to thank you for attending this presentation on colon screening, who, why, and when. The presentation will discuss a brief description of the related health issue, colorectal cancer, and the stakeholders involved to ensure continued importance of colon screening. Colorectal cancer and colon cancer are often synonymous in terms because they are grouped together because of their similar physiological symptoms. The distinction is dependent on whether the colon is just affected or if it's both the colon and rectum that are involved. For this presentation, we'll be focusing on the data that's reflective of colorectal cancer incident rates within the United States. Affecting both men and women in the United States, colorectal cancer, according to the CDC, ranks as the second leading cancer-related cause to deaths, and it's recognized by the American Cancer Society as the third most diagnosed cancer. Screening allows for early detection and prevention. The percentage of the United States adults ages 50 to 75 years who were up to date with colorectal cancer screening increased by 1.1 percentage point from 66.2% in 2014 to 67.3% in 2016. This represents an additional 3.3 million adults that were screened for colorectal cancer. By reviewing colorectal cancer rates, we can find and help to compare how the trend for screening can be warranted. When colorectal cancer is found at an early stage before it has spread, the 5-year relative survival rate is about 90%. Unfortunately, about 1 in 3 people in the U.S. who should get tested for colorectal cancer have never been screened. So by looking at states and ethnicities, we can hopefully find trends for increased screening campaigns that may be warranted throughout our country. Any campaign to promote any health issue needs to look at the signs and symptoms of that problem. And with colon cancer, we know that the signs are changes in stool content, the feeling of that the bowel has not fully emptied, bright red bleeding from the rectum, the stool appears darker in color, there may be abdominal pain or cramping, a feeling of weakness or fatigue, and weight loss without intention. The risk factors for colorectal cancer can be inherited or lifestyle related. Inherited risk factors include our personal or family history, inflammatory bowel disease, our ethnic and racial backgrounds, and our type 2 diabetic status. Lifestyle risk factors include overweight, physical inactivity, our diet selection, smoking preference, and our alcohol consumption. With any campaign, we want to keep up with the latest guidelines and changes. And recently, for those who aren't aware, as of May 30th, 2018, the American Cancer Society is now recommending colon screening starting at the age of 45. The American Cancer Society predicts an expected 50,630 deaths related to these cancers this year, 2018. For men, there's a lifetime risk of developing colorectal cancer, approximately 1 in 22, and for women, 1 in 24. The data used for this presentation came from the colorectal cancer statistics from the CDC and the Agency for Healthcare Research and Quality. This graph displays the United States incident rate difference between men and women. You can see that the male colorectal cancer incident rates are higher than the females. The males, 45.9 average annual rate per 100,000, compared to the females, 34.8 average annual rate per 100,000. And this data was from the years 2010 through 2014. We broke the data down further to identify ethnicity, race, and sex, as well as a division of colon versus colorectal cancer incident rates. The three leading ethnicities for colorectal cancer were the non-Hispanic Black male, with an incident rate of 56.4 per 100,000 population, the American Indian and Alaskan Native male with an incident rate of 50.1 per 100,000 population, and third, the non-Hispanic white male with an incident rate of 45.2 per 100,000 population. This graph gives the incident rates of the combined sexes in each ethnic race category. Again, the highest average annual incident rate for colorectal cancer falls to the non-Hispanic Black ethnicity with 47.4 per 100,000 population. We took it another step to include specific areas of the country. We wanted to see how the rates looked like throughout the states. And the states with the highest incident rates of colorectal cancer were Kentucky, Mississippi, and Louisiana. We graphed that on a map so that we could see across the country how it appeared. And we can see Kentucky, which came in at 59.3 per 100,000 population. The next, Mississippi, was 58.2, and then Louisiana at 56. So who are our potential stakeholders that are affected by colon screening? We know the clients are the patients and the family members. We know that their nurses are involved, and caregivers and physicians, the administration, the scheduling, our pharmacies, and of course, our insurance companies and our financial ends. So we want to take those stakeholders and then group them to identify the groups. We see we have a group of clientele, our healthcare professionals, our healthcare services, our financial services, and then a group of health information, our marketing department, our data research. We take these groups and put them into what's called an influence diagram. This is a visual representation that shows the group's connections to the colon screening. Influential elements that are included are such things as education, data collection, and cost aspects, and how each of those are affected by the actual participation of the group, its member, or the activity of the colon screening. With the inclusion of our stakeholder groups, the sharing of data, and targeting select states for research, this will allow focus on areas of high colorectal cancer incident rates. As an example, starting in this area, the Arkansas, Louisiana, and Mississippi states, our mid-southern United States, we can offer a view of the ethnicities and racial populations. It will also allow us to examine the risk factors that are there. And then those findings will help guide the changes needed to increase knowledge, lifestyle alterations, and screening participation to such high incident rate areas. And the message then that we want to offer the target areas is what the person can do to improve their chances against colorectal cancers. What they can do, they can see their healthcare provider, their family practice or gastroenterologist. They can make lifestyle changes. We can discuss weight management, physical activity, diet, smoking cessation, and alcohol consumption. And then, of course, the testing, fecal examination, colonoscopies, and DNA. Overall, this campaign will focus on increasing colon screening to aid in early detection and improve quality of life. Thank you for listening.